By the time the first tremor appears, the moment that brings most people into a neurologist's office for the very first time, the biological process causing that tremor may have already been underway for 10 to 20 years. And by that same moment of first diagnosis, somewhere between 60 and 80% of the specific neurons responsible for controlling smooth, coordinated movement have already been lost, 60 to 80% gone before the first symptom was ever noticed. This is the defining feature of Parkinson's disease that most people never hear at their first appointment. The visible disease, the tremor, the stiffness, the slowed movement, is not the beginning of the process. It is the point where the damage finally crosses a threshold the brain can no longer compensate for. Today I am walking through every single stage of Parkinson's disease, including the stage that happens before any diagnosis is even possible. What the disease is doing inside the brain at each stage, what the person themselves experiences, what the family and caregivers around them are quietly going through, and what each stage means for the decisions that lie ahead. Here is the number that puts this entire video in context. Parkinson's disease is the fastest growing neurological disease in the world. That finding was published in JAMA Neurology in 2018 by researchers who analyzed global Parkinson's disease trends across 5 full decades. The number of people living with Parkinson's has more than doubled in the last 25 years. In the United States, approximately 1 million people are currently living with Parkinson's disease. Approximately 90,000 new diagnoses are made each and every year, a number that represents a 50% increase from estimates made less than a decade ago. Parkinson's disease is not rare, it is common, it is growing, and it is significantly underrepresented in public health conversations relative to its actual prevalence. Understanding the stages matters not just for people with Parkinson's, but for the families and caregivers who will walk through those stages right alongside them. Most people receive a diagnosis without a clear explanation of what the progression actually looks like. This video is that explanation. Subscribe now and help Dr. Ryan Foster reach the people who need this most. The most limiting misconception about Parkinson's disease is that it is a movement disorder with tremor as its defining feature. Tremor is one of the most visible and well-known symptoms, but Parkinson's disease is a neurodegenerative condition that affects far more than movement. It affects sleep, mood, cognition, digestion, blood pressure regulation, and even the sense of smell, often years before the tremor appears. The reason this matters so much is that most of the earliest warning signs of Parkinson's disease are not movement symptoms at all, they are non-motor symptoms. Changes in the gut, in sleep, in emotional regulation, in sensory experience that precede the motor symptoms by years and sometimes by decades. If Parkinson's disease is understood only as a tremor, the opportunity to identify it early, before the majority of relevant neurons have been lost, is consistently and tragically missed. Here is what you will leave this video knowing: the 5 clinical stages of Parkinson's disease, what is happening in the brain at each one, what the person experiences, and what the family around them is going through. I am also going to walk through the stage that comes before all 5, the prodromal phase, where the disease is quietly building before any diagnosis is even possible. For yourself, if you or someone close to you has received a Parkinson's diagnosis, this is the framework for understanding what you are actually dealing with and what to expect honestly, clearly, and without the vagueness that most initial appointments leave behind. For a loved one, if you are watching for a parent, a partner, or a person whose diagnosis you are trying to understand, this video will give you the language and the framework to be a more informed presence in their care. I also want to be direct about something that this channel covers extensively in other videos. Approximately 50 to 80% of people with Parkinson's disease will develop dementia during the course of their illness. We will address this specifically in the later stages, because families deserve to understand this trajectory before they encounter it unprepared. Let us start before stage 1. Let us start where the disease actually begins, before the stages. 2 minutes on the biology, because understanding the mechanism makes everything that follows make sense. Parkinson's disease is caused by the loss of neurons in a small region deep in the brain called the substantia nigra. The name means black substance in Latin, because in a healthy brain this region is visibly dark, stained by a neuromelanin pigment produced by the neurons within it. In a brain with advanced Parkinson's disease, this same region is visibly pale at autopsy. The dark neurons are gone. These neurons produce a neurotransmitter called dopamine. Dopamine travels from the substantia nigra to a region called the striatum, where it enables the smooth, coordinated control of movement. When dopamine levels fall, because the neurons producing it have died, movement becomes impaired, slower, stiffer, less precise, and harder to initiate. What kills these neurons is the formation of abnormal protein deposits called Lewy bodies, the same alpha-synuclein aggregates we discussed in the Lewy body dementia video on this channel. As Lewy bodies form inside neurons, they disrupt cellular function and eventually cause the neurons to die. Here is the critical timing point: the brain compensates. As neurons begin dying in the substantia nigra, the remaining neurons work harder and more efficiently to maintain function. Dopamine is used more effectively. Alternative pathways are recruited. the brain masks the loss for years. By the time the compensation finally fails, by the time the tremor appears and the diagnosis is made, 60 to 80% of the relevant neurons may already be gone. The disease has been building in silence for a decade or more. This is why stage 0, the stage before the diagnosis, matters more than most people realize. Stage 0, before the diagnosis, the prodromal phase. Prodromal means preceding the main symptoms. In Parkinson's disease, this phase can begin 10 to 20 years before the first motor symptom ever appears, and it is not symptom-free. It has its own distinct set of signs, non-motor signs, that are now recognized as some of the earliest indicators of the disease. The first is anosmia, the loss of the sense of smell, not a cold, not allergies, a persistent, progressive reduction in the ability to detect odors that has no other explanation. Research has found that anosmia is present in up to 90% of Parkinson's patients and often precedes motor symptoms by years. Many people simply attribute it to aging. A significant number never mention it to a doctor at all. The second is constipation, chronic, treatment-resistant constipation that is out of character for the person and has no obvious dietary cause. Research by Brock and colleagues established that Parkinson's pathology, the alpha-synuclein aggregates, may actually begin in the gut before spreading to the brain along neural pathways. Constipation as an early sign of Parkinson's has been documented in multiple large studies. The third is REM sleep behavior disorder. In normal REM sleep, the body is temporarily paralyzed. In REM sleep behavior disorder, that paralysis fails. The person physically acts out their dreams, talking, shouting, sometimes striking out in ways that can injure themselves or a sleeping partner. Research published by Postuma and colleagues established that REM sleep behavior disorder precedes Parkinson's motor symptoms in many patients, sometimes by a decade or more. It is one of the most reliable early indicators of the condition. The fourth is depression and anxiety that appears without any obvious external cause. Changes in mood regulation are a recognized non-motor early feature, reflecting the disruption of dopamine and other neurotransmitter systems that begins well before movement symptoms emerge. Do not let stage 0 feel like an abstraction. These are real symptoms that real people experience for years before a neurologist ever connects them to Parkinson's disease. A person with persistent loss of smell, chronic constipation, and a partner who reports that they kick and shout in their sleep may be in stage 0 of a condition that will not be diagnosed for another full decade. If multiple prodromal features are present, particularly the combination of anosmia, constipation, and sleep behavior disorder, a conversation with a neurologist is appropriate and worthwhile. Stage 0 is the disease before it has a name. Stage 1 is the first stage where it becomes clinically visible. Stage 1, the earliest clinical stage of Parkinson's disease. Using the Hone and Yahr scale, the most widely used staging system, first published in 1967 and still in clinical use today, Stage 1 is defined by symptoms affecting only one side of the body. The tremor, if present, appears in one hand, one arm, or one leg, not both, just one side. The stiffness and slowness of movement, called bradykinesia, may also be unilateral. The characteristic resting tremor of Parkinson's disease, which diminishes during intentional movement and returns at rest, is the symptom most people recognize, but tremor is absent in approximately 20 to 30% of Parkinson's diagnoses. Not every Parkinson's patient shakes. Other stage 1 changes that families often notice before the person themselves include a reduction in arm swing on one side when walking, a slight change in facial expression, the face becoming less animated, less reactive, called hypomimia, a softening and quieting of the voice, called hypophonia, and a change in handwriting where letters become smaller and more cramped, called micrographia. Daily life in stage 1 is largely maintained. The person can still live independently, work, drive, and manage their routine. The symptoms are real and noticeable, particularly to someone who knows the person well, but they do not yet significantly impair function. The critical issue at stage 1 is diagnoses. Because symptoms are mild and unilateral, many people and their doctors attribute them to musculoskeletal problems, overuse injury, or normal aging. The average time from symptom onset to diagnoses for Parkinson's disease is more than a year in most studies. That delay matters not because treatment can reverse damage, but because it delays the establishment of a care team, lifestyle strategies, and the planning that stage 2 makes far more urgent. Stage 1 is one side of the body. Stage 2 is when the disease crosses the midline. Stage 2 symptoms affect both sides of the body. The tremor, stiffness, or slowness that was limited to one side in stage 1 now involves the other side as well. Movement is slower overall. Tasks that once took 30 minutes take 45 or 60. The change is cumulative and consistent. Facial expression continues to diminish. The voice continues to soften. People who know the person well notice that something essential about their expressiveness has changed, not their personality, but the physical bandwidth through which personality is communicated. The face that laughed easily now requires more effort to animate. The posture changes become more visible in stage 2. A slight forward flexion, a modest stooping becomes apparent. Footsteps may begin to shuffle rather than step cleanly. Turning around, getting out of a chair, and initiating movement from stillness all require more deliberate effort. Crucially, balance in stage 2 remains functional. The person can still catch themselves from a stumble. They can still live independently and manage daily activities, though with greater effort and at a slower pace. Non-motor symptoms that were present in stage 0 often intensify in stage 2. Sleep disruption, constipation, mood changes, cognitive slowing, and reduced processing speed. These symptoms are frequently undertreated because the appointment focuses on motor function, which is visible, measurable, and the primary concern of the staging system. The non-motor burden of stage 2 is often heavier than the motor burden for the person actually living through it. Stage 2 still looks like independence. Stage 3 is where independence begins to be genuinely threatened. Stage 3, the defining feature of this stage, the clinical marker that separates stage 2 from stage 3, is balance impairment, specifically postural instability. The person can no longer reliably catch themselves from an unexpected loss of balance. Falls begin to occur, not always frequently in early stage 3, but consistently enough that falls become a clinical concern and a daily safety consideration. Neurologists test this with what is called the pull test. Standing behind the patient, they give a sudden firm pull backward on the shoulders. A healthy person, or someone in stage 1 or 2, takes one step back to maintain balance. A person in stage 3 takes multiple steps back or cannot correct at all. The postural reflexes that catch us automatically are no longer reliable. Falls in Parkinson's disease are not minor. They are one of the leading causes of hospitalization and serious injury in people with the disease. The combination of slowed movement, rigidity, and impaired postural reflexes means that when a fall begins, the body cannot respond quickly enough to interrupt it. A hip fracture in stage 3 is not just a physical injury, it changes the entire trajectory of care. The person in stage 3 is still physically independent for most activities and can still live alone, though with increasing risk. Driving should be carefully evaluated by this stage. Reaction time, spatial awareness, and the ability to respond to unexpected events are all affected. For a loved one, stage 3 is the stage where home safety modifications become urgent rather than optional. Grab bars, shower seats, the removal of trip hazards, non-slip surfaces, these are not premature. They are timely interventions that prevent the injuries that drive the most rapid functional decline in Parkinson's disease. Stage 3 still permits independence. Stage 4 does not. Stage 4, the transition from difficult independence to genuine dependence. In stage 4, the person can still stand and walk, often with a walker or other mobility aid, but they cannot safely live alone. The physical demands of daily life have exceeded what the disease allows them to manage without consistent assistance. Dressing, bathing, preparing meals, managing medication schedules all require help. Falls are more frequent and more dangerous. The non-motor symptoms that were present in earlier stages intensify significantly in stage 4. Sleep disruption becomes severe. Constipation may require active medical management. Blood pressure regulation fails in a condition called orthostatic hypotension. Blood pressure drops dramatically when standing, causing dizziness and increasing fall risk. Pain, fatigue, and anxiety are common. And in stage 4, cognitive changes become a prominent clinical concern. This is where I need to say directly what many families are not told clearly. Parkinson's disease dementia, the cognitive decline associated with long-standing Parkinson's disease, affects between 50 and 80% of people with Parkinson's. Most people with stage 4 Parkinson's have some degree of measurable cognitive impairment. For a significant number, full dementia develops in stage 4 and stage 5. The profile of this cognitive change differs somewhat from Alzheimer's disease. Attention, processing speed, and visual spatial skills are often affected first. Memory is impaired, but not always as prominently as in Alzheimer's. Hallucinations, particularly visual hallucinations, the same feature we discussed in Lewy body dementia, are common in stage 4 and 5 and can be profoundly distressing for families who have not been warned. This is not a coincidence. Parkinson's disease dementia and Lewy body dementia share the same underlying pathology, alpha-synuclein aggregates in the same type of location. They are closely related conditions. The Lewy body dementia video on this channel discusses this pathology in depth. For a loved one at stage 4, the same antipsychotic medication sensitivity warning that applies to Lewy body dementia applies here. Certain antipsychotic medications used to manage behavioral symptoms can cause severe, sometimes life-threatening reactions in people with Parkinson's disease for the same underlying neurological reasons. Any medical team managing behavioral symptoms in someone with Parkinson's must be specifically informed of this risk before any antipsychotic is prescribed. Stage 4 brings the full weight of the disease into daily life. Stage 5 is the final stage, and it requires the clearest possible understanding before families ever reach it. Stage 5, the most advanced stage of Parkinson's disease. In Stage 5, the person is unable to walk safely and is wheelchair-bound or bedridden. Every activity of daily life requires full assistance from another person. The motor symptoms that began as a unilateral tremor in Stage 1 have progressed over years to a state of near total motor dependency. The swallowing reflex deteriorates in Stage 5, a condition called dysphagia. Food and liquid begin entering the airway rather than the esophagus, creating risk of aspiration. Mealtimes require careful technique, modified food textures, and thickened liquids. This is the same end-stage process we described in the What Dying from Dementia video on this channel. Because the underlying mechanism is related, the brain losing its capacity to coordinate complex muscular sequences fails first at the most recently learned and most demanding of those sequences. Dementia is present in most people who reach Stage 5. Hallucinations, confusion, and significant memory impairment are common. The person may not reliably recognize family members, they may have limited verbal communication, and yet what we have said in multiple videos on this channel remains true here too. Some responses remain when almost everything else has been taken. The response to a familiar voice, the response to touch, the response to music, these are not imagined. They reflect the survival of the most fundamental and ancient neural systems in the brain, systems that Parkinson's disease, like Alzheimer's, reaches last rather than first. Most people with Parkinson's disease do not die from the disease itself, they die from its complications. Aspiration pneumonia being the most common, along with the consequences of falls and prolonged immobility. The cause of death certificate may not even say Parkinson's. The cause of death is what Parkinson's eventually makes impossible to prevent. The advance directive, the documented statement of what the person wants for their medical care at this stage, must be written during Stage 3 or Stage 4, while the person can still fully and clearly participate in making it. Stage 5 is not the time to make those decisions. It is the time to follow the decisions already made. Before we close, I want to address the cognitive trajectory directly, because it is the aspect of Parkinson's disease least clearly explained to families at diagnosis. 50 to 80% of people with Parkinson's disease will develop dementia during the course of their illness. This is not a rare complication, it is a common and documented part of the disease's natural history for the majority of patients. The Parkinson's disease dementia that develops in later stages shares its underlying pathology with Lewy body dementia. Both involve alpha-synuclein Lewy body accumulation in neurons. The distinction between the two diagnoses is primarily one of timing. If cognitive symptoms appear within 1 year of motor symptoms, the diagnosis is Lewy body dementia. If they appear more than 1 year after established motor symptoms, the diagnosis is Parkinson's disease dementia. The brain pathology is closely related. Families who are not warned about this connection encounter the cognitive changes in Stage 4 and Stage 5 as a surprise, a second disease arriving without explanation. In reality, they are watching the later expression of the very same neurodegenerative process that produced the tremor back in Stage 1. If you are the family member of someone with Parkinson's disease, and this is the first time you have heard clearly that dementia is a probable part of the progression, the Every Type of Dementia video on this channel covers Parkinson's disease dementia specifically in the context of all 6 major dementia types. It is worth watching before Stage 4 makes it urgently relevant. Parkinson's disease has no cure. What the research does support is a set of interventions that can meaningfully influence the rate of progression and the quality of life across the stages. Exercise is the most consistently supported modifiable factor in Parkinson's disease. High-intensity aerobic exercise, balance training, resistance training, and activities like boxing, dancing, and Tai Chi have all been studied and shown to improve motor symptoms, slow certain aspects of decline, and support cognitive function in people with Parkinson's. This is not a gentle suggestion. Multiple randomized controlled trials have shown measurable benefit. Sleep management, specifically addressing REM sleep behavior disorder and the sleep disruptions common from Stage 2 onward, improves both quality of life and cognitive function. Social connection and cognitive engagement, what we discuss throughout this channel as cognitive reserve, protect the brain in Parkinson's disease, as they do in Alzheimer's disease. The neural redundancy built through an active cognitive life provides a buffer against the spread of Parkinson's pathology into cognitive regions. These are not cures, they are tools. In a disease where 60 to 80% of the relevant neurons are already gone by diagnosis, every single tool that preserves the remaining function matters enormously. One question in the comments before you go. Which stage of Parkinson's disease were you least familiar with before this video? And which stage most describes the person you are watching this for? Just the number. Stage 0 through Stage 5. I read every comment, and the answers shape what this channel covers next. If this gave someone you love a clearer picture of what Parkinson's disease actually looks like across time, share this video with them. With the family member who keeps asking what to expect, with the caregiver who is in stage 3 right now and needed to see stage 4 described honestly before arriving there. Dr. Ryan Foster made this so that no family walks these stages blind.